the tailbone, which is called the coccyx, we came up with the name a pain in the butt. We thought that was a little fun, little cheeky. This will be the star of our show here, the coccyx, the end of the spine. And I'll tell you a little bit about myself. So I've been a pelvic health PT for almost as long as I've been a PT, so almost 11 years now. I support clients in pregnancy, preparing for birth, in postpartum, and also throughout the lifespan. And that's clients of all genders. Everybody has a pelvic floor and most people have a tailbone. So this can be useful information for everybody. I see clients in person, and I also started doing virtual sessions during COVID, but I love the virtual work. I feel like it makes healthcare really accessible, and I can speak with people and help people get started, even if it's hard for them to get out of the house. So if they are in the pregnancy, it's difficult for them to come see someone in person, or early postpartum, or just in general, having a lower barrier to contact and care has been really helpful. And I have 2 little kids myself. So the coccyx, that's a name for the tailbone. The coccyx is made up of 3 to 5 vertebral segments. So there is, in the research, they speak about extensive variability in the joint structure. And I thought this was interesting because I didn't really learn that in school. And when I palpate or feel down people's spine and down people's coccyx over the years, I was like, oh, that's interesting. Like, that made sense to me, that there is this variability in how much the coccyx moves and what the coccyx feels like and the shape that it takes in different people. The individual joints may have less movement or more movement, and certain configurations in the research, the papers speak about, may be prone to having more coccyx pain. I'm going to go over a little bit of anatomy, and there's no exam or anything, but what I thought is interesting is I think many providers think about the coccyx as a bit unimportant, and not the providers on here, but in general, I think there's this idea of like, oh, it's just a little bit of your spine at the end and it doesn't really do anything. So I just wanted to show some anatomy to bring light to the fact that there's a lot of important attachments here to different ligaments. So these are some of the ligaments here. A ligament that goes from the front of the sacrum to the tailbone, ligaments that go from the sacrum down to other parts of the pelvis. That's the sacrospinous and sacrotuberous ligaments. And then in my world as a pelvic floor therapist, even more interesting to me are all of the muscle attachments to the coccyx. So the coccyx is the attachment point for many of the pelvic floor muscles, hence their names. So iliococcygeus, that's a deep pelvic floor muscle. And the name describes its origin and its attachment. So it goes from part of the pelvis called the ilium to the coccyx. Same thing with pubococcygeus and the coccygeus muscle, as well as the sum of fibers from the gluteus maximus. So that's the bigger part of your glutes. So when people talk about the coccyx, for me as a pelvic floor therapist, it's very important. It is the attachment point for many of the muscles that I am working with. So coccyx is a big star in my world. And it does have function. So again, I like to think that the coccyx is really important instead of just an afterthought. So like I had just mentioned, it's an insertion site for many pelvic floor muscles and ligaments. And what's important about that? Well, the pelvic floor is really important. It's what allows us to go to the bathroom. Urination, defecation, that is 2 of the very important things that the pelvic floor muscles control, as well as sexual function. So the contraction and relaxation of the pelvic floor is what helps us have these functions. And it wouldn't be able to do so without an attachment site of the coccyx. Interestingly, the coccyx also provides some positional support for the anal sphincter. So that's actually something I did not really learn much in school either, that the anatomy helps give position and support for the anal sphincter, which is obviously also very important for having voluntary bowel movements and control of our bowel movements. And in sitting, the papers, the research talk about how the coccyx forms a bit of a tripod between the sit bones and the coccyx for seated support. So let's talk about, we're going to talk about pregnancy and then the birth itself and postpartum. So if there's folks in here at any of those stages, I'll give an overview, and then I would be very happy to answer questions and have discussion that takes a deeper dive into some of these things. So in pregnancy, what do I think about? And everybody has their own lens to see these issues through. So for me as a pelvic floor therapist, when I'm thinking about tailbone pain in pregnancy, I'm thinking about, why did this pop up in the pregnancy? Maybe there's some adaptations to the growing pregnant belly. So some of the things I often see, and I was going to try to find a picture, but I couldn't find a good picture. Maybe I'll just show. Caprice, can they see me on the side? Well, okay. So one of the things that I see oftentimes is that the pelvis might be kind of tucked under, right? So people are gripping their bottom. And if they're gripping their bottom, they might be gripping their pelvic floor, and the tailbone might be also gripping. So in pregnancy, sometimes we see this kind of tucked position, depending on how people use their bodies. What I see maybe more often is this pelvis just kind of push forward as the belly grows. So belly grows forward, pelvis kind of just slides forward. And again, that might create some shortening or some tension on the back half. So those are some of the things I'm thinking about in terms of someone's tendencies. As a physical therapist, I'm not very big on people needing to have perfect posture, but I think more about what someone's tendency is. So when I look at someone in standing, if they always seem to go to one position and they're having some pain, then I like to see, can I challenge them to come into a different position or more variability in positions? And that might decrease some tension in areas where they're having discomfort. I also see in pregnancy, for myself as a pelvic floor therapist, I do check people's pelvic floor muscles in pregnancy. I can check that externally, like I can palpate around someone's sitting bones, but I do also perform internal palpation of the pelvic floor muscles, and that's intravaginally in pregnancy. And what I've noticed over the years is that the further along we get in pregnancy, I find that the deep pelvic floor muscles that attach to the tailbone tend to start getting tighter and tighter and tighter. And my own hypothesis is that maybe the pelvic floor is compensating for the core. So the core goes through a really huge change, right? The muscles really extend a great deal. And I think the pelvic floor starts to try to make up for some of that loss of control or tension in the body. Also, of course, there's a downward pressure of the baby, but like I said, my own hypothesis, I think the pelvic floor starts to try to help out late in the pregnancy. So remember, those deep pelvic floor muscles attached to the coccyx. So I start to see a lot of tension there. Another thing that I see is sometimes people have been told, or maybe just on their own, there was this cultural idea that for childbirth, the way to prepare is to do a lot of Kegels. And a Kegel is the name for a pelvic floor contraction. So there is like one birth class methodology that tells people, I believe, to do 100 Kegels a day. So I know, Caprice, I see your face. This is what I have heard from people. I did not take this method, but the idea that sometimes I see clients who they've been doing a lot of Kegels, and a Kegel is a contraction, and maybe they haven't been taught that the relaxation is just as important, or maybe it's just too much tension. A lot of folks that I see already have pelvic floor muscles that ride on the kind of more tense side. So everyone's pelvic floor in my world is on a bit of a spectrum. There's pelvic floors that the muscles sit nice and kind of relaxed at rest. What I see, most of the clients I see, there's a bit of tension in the pelvic floor. So someone that's been told to do a whole lot of Kegels, if the pelvic floor was my bicep, right, a Kegel is like a squeeze, and then there's a relaxation. So I might see someone that's been doing a lot of squeezing, and now there's been no really attention to relaxation, or the muscles just kind of really like being in that position. And the tailbone, which attaches to the pelvic floor, might also have become really tucked under, and it's just kind of hanging out there. So that is another thing I see oftentimes in pregnancy. I also see
Rachel,
yeah.
Sorry, I'm wondering, we've had a question come up on internal work during pregnancy, and maybe this is a good time to talk about it, maybe it's not. Sure. But some folks may be under the impression that there's no internal work done typically during pregnancy. Maybe you could speak to that quickly.
Sure. So I think it depends on the physical therapist and their level of comfort and their communication with the physician. So personally, in my own practice, I like to have the okay of the care provider, the OB or the midwife. I tend to check the pelvic floor later in pregnancy. I stay away from doing it earlier on in the first trimester unless there's like a really significant reason to check and the provider and the client are both on board. So, and if that varies across physical therapy. So we feel it is in our jurisdiction to do that, but I think it depends on the therapist and their comfort level and their amount of training to check the pelvic floor. Just let me know if there's further. I can go into that further if there are questions. For me, I'm doing like a really kind of quick, gentle check. We're not going up towards the cervix, so it doesn't feel really as deep as like a pelvic exam. We're using a gloved finger, and I'm checking for overall tension. Are the muscles hanging out really gripped? Are they softer? Someone's ability to relax their pelvic floor and squeeze their pelvic floor. And I might be able to feel if the tailbone is very, very, very flexed under. Sometimes when I'm doing an intravaginal exam, I can feel it, and it gives me some more information. So I hope that answers that question. Yeah, I'm happy. We can dive into anything deeper as we go along. I wrote here, old injuries becoming irritated. So again, I think that sometimes people have an injury, an old fall, and things are good. The body has learned how to deal with that injury. But as the body changes in pregnancy, as the core elongates, as the pelvis changes, the body's trying to figure out, how do I go along my normal function? And some of that old injury, if the tailbone's in a bit of a non-ideal position, can start to, like, as the body starts to compensate, some of those things become more obvious. And I just picked on snowboarding. It's not, I love skiing, but I just see snowboarding is a lot of falling on the bum. So I do see that old snowboarding stuff kind of come into play. So I'm going to talk about self-treatment first, and then what I will do as a physical therapist. So these are the things that I discuss with my clients. I look at their posture, then ask them to have an awareness of their postural tendencies. Again, just tendencies. Posture doesn't have to be perfect, but if you tend to do one thing all the time, if you tend to sit really slouched down all the time, if you tend to tuck your butt under all the time, tuning into some of those things can be helpful in the treatment. I ask people similarly to check in with their tendencies in terms of their glutes or their pelvic floor. Once they learn what it feels like to squeeze their pelvic floor and relax their pelvic floor, when they check in during the day, are they in like a constant squeeze or in gripping? I took a course, this wasn't for me, but I took a course with somebody and another therapist, and he said, when you're standing, can you picture that your tailbone is so loose that you could use your tailbone to squiggle your name? So that's not a very scientific test, but I think awareness wise, I just always like that one. Like when you're standing, do you have enough relaxation in that area that you could kind of wiggle it around? So I like that one. In terms of self-treatment, again, focusing on harnessing the breath to increase elongation in the pelvic floor, to decrease tension in the pelvic floor. Some therapists call this the reverse Kegel. I don't love the name, but I don't have a better name. The idea is, again, like a squeeze as a contraction. And for a lot of people, this relaxation is a little bit more subtle. So maybe the muscle just has like a 30% tension. And how can we just see if we can decrease some tension in the pelvic floor? There are movements that can increase this awareness of decreasing tension in the pelvic floor or the tailbone kind of untucking. You're coming out of that really engaged position. Things like cat-cow, child's pose, tabletop stretch would just be like a modified downward dog, like a nice spinal extension. Just things that take you out of that gripped position and give you some awareness of where your body is in space. And then if you saw a PT or another health professional, I do teach my clients some hands-on techniques that they can do on their own, where they can use their fingers to do a little bit of trigger point kind of massage. So that's like a press and hold massage to the muscles along the coccyx and a little bit of stretching by the glutes. So that's something that someone can do on their own. As a physical therapist, something beyond what we just talked about is that I can try to assess which structure is actually generating the discomfort. So, what I find often is what feels like the tailbone itself. I find a lot of pain in the muscles as they come in and attach to the tailbone. So, I'm trying to figure out, is it one side? Is it the other side? Is it both sides? Is it the bone itself? Interestingly, I had this actually yesterday with a client where we don't have good awareness in this area. It's not like when we're growing up. I always say, like in gym class, they're not like, ooh, feel your tailbone and feel your pelvic floor. So I had a client yesterday who's postpartum and she said, my tailbone feels all weird. And then when I palpated down her tailbone, she said, that's really not it. I think it's higher. And for her, it was more her sacrum. So seeing someone in person can help assess. You're having some discomfort. Where is that coming from? Again, as a physical therapist, I'm assessing the pelvic floor for tension or tendencies. Does someone tend to overgrip their pelvic floor? Again, I can assess that externally. I can feel it by their sit bones. I can have someone lie on their side and I can just feel their tailbone as they kegel and relax and feel the position. Is there equal space on both sides of the tailbone? Is it tending towards one side or the other? And again, as a physical therapist, I'm doing a little bit of what we call manual therapy, so massage like techniques or some gentle, what we would call mobilization techniques. Can we move tissues and sometimes skeletal bones and positions of the spine? Can we get things feeling more even and equal? And that can be done externally. I don't really manipulate the coccyx itself directly in pregnancy, meaning sometimes I can feel it vaginally if it's very tucked under. The most direct way for a physical therapist to get on the tailbone itself internally would be rectally. It's closer to the tailbone, but I don't really do that in pregnancy. So mostly in pregnancy, I am checking sometimes internal, but I'm working externally mostly, and I have some techniques that we do externally.
Rachel, we had another question sort of tangentially, I guess, on these lines that are you able to feel whether, I guess, internal or external, if the tailbone is fused? Could you feel that with an internal exam?
So I would say I don't have enough confidence that I would be able to differentiate what's going on at the different vertebrae of the tailbone. I don't often feel, it's hard to say. I don't often feel like a ton of movement where I could say, okay, like between these two, there's movement, and between these two, there's not movement. I think radiology, like x-rays, might be better at that. And it's interesting. So Dr. Foy is on this call, and some stuff is stuff that I think he would have the answers to a little bit better. So I'm putting you on the spot, but it's stuff as a physical therapist where I'm really looking more at function and the muscle attachments to the tailbone, rather than, I don't feel like my work is specific enough to say like this is the exact shape of your tailbone or location. I'm saying, okay, like right side to left side feels different. It seems to be tucked under or extended too much. And I'm looking at more of those functional things.
Dr. Foy is also throwing some great stuff in the chat here too.
Oh, I can't even see it.
Well, you know, it's my job. You don't have to worry about it. You know, Dr. Foy. And so folks, if you're not checking in the chat box, check in the chat box now, because Dr. Foy is throwing some good info in there for us.
All right, let's see. So let's talk about birth. Now, I try not to use pictures I don't have permission for. So all those other pictures I have permission for, I did put the little link here. But I didn't have an illustration for this. So I'm not in the birth room with people except for my own birth. So if there's doulas out there, you guys are really there at the moment of birth. But ideally, we think the sacrum and the tailbone should have room for movement in birth. So when I see someone in pregnancy and they're already having tailbone pain, I am encouraging them to come in for treatment, because to me, that means the tailbone might be a bit tucked under or leaning towards one side. And I want to give them the best opportunity for a birth where the delivery of a baby vaginally doesn't irritate their tailbone. So in this picture to the side, we see the sacrum starts to come out or away from the body, and the tailbone is attached to the sacrum. So I think for some people, it's a great photo to show that when someone is on their back, we lose that degree of movement that is possible in the sacrum. So in terms of the tailbone, the more favorable pushing positions for pushing or second stage of labor would be what we call as physical therapists high kneeling. I think people would just call it kneeling, right? So up on the knees, right? And maybe leaning forward. That's what we call high kneeling. Hands and knees, side lying. I wrote squatting just with a question mark because I think for the tailbone, it's fine. As a pelvic floor therapist, I get a little bit worried that maybe there's a lot of uncontrolled pressure on the perineum, but I think that babies and birthing people work together to find the best position. So I'm not saying it's a bad position. I think I gave birth actually on my back without an epidural, and I tried squatting and kneeling, and I don't like to demonize any position. That position worked for me, and I wasn't sitting there worried what was happening to my tailbone. So it can all work, but this is just if we're thinking about the anatomy and the birthing process, these are the more favorable positions. I did see, so I say I'm not in the births, I did see a doula recently post an idea where if a client is on their back or if you're the person giving birth, that maybe putting towel support, like folded towels on either side of the pelvis could give a little room for the sacrum and tailbone to move. So I'm not sure if in practice that like a little bit of a towel would give enough freedom of movement, but I thought it was an interesting idea. So I don't know if anyone wants to comment on that. We can chat about it later.
Yeah, throw in the chat if you're a birth worker and you've used that technique or you've seen that technique. Tell us in the chat.
I thought it was just an interesting direction to go in. Like, okay, maybe even on your back, there's a way to maybe create some more room. All right. So I do see folks now, someone that has tailbone pain in pregnancy is not necessarily someone that will have pain postpartum. And someone that has pain postpartum may have had no pain in the pregnancy. So sometimes in the pregnancy, it's more these postural tendencies or pelvic floor tendencies or old injuries. Sometimes in the birth, the way that a baby is birthed might cause irritation to the tailbone. So early postpartum care of tailbone pain, this is not going to look too different than other early postpartum care. So prioritizing rest, which is really hard to do in our society, which is why I wrote, is there help for the postpartum person? The person will have trouble sitting. They will have trouble lying on their back sometimes. Side lying may be the most comfortable. This person's going to need help feeding their baby and taking care of their baby and getting food and all of the things that you guys at Birthsmarter help people prepare for in the postpartum period, right? Yeah. A cushion may help. I'd be curious if Dr. Foy tells us later what he recommends, maybe if he wants to share what kind of cushions may help. So traditionally, like there's this recommendation for donuts. We think it kind of maybe puts too much pressure on the tailbone. Also for the postpartum person, I feel like it leaves the perineum really unsupported. The perineum is the spot between the vaginal opening and the anal sphincter. And the donut creates a little bit of like a vacuum for that area, similar to sitting on the toilet. So I think a lot of people aren't big fans of donut cushions. There are specific Coccyx cushions, so they're a little bit wedged. They have a cutout for the Coccyx. As a pelvic floor therapist, I've had some people with success with gel cushions that have support under the sitting bones, and then there's a little bit of a channel for the perineum, and the Coccyx would fall within that little bit of a channel. I'm curious to hear about this too. So Frida Mom now makes a cushion. I feel like it's not as deep as a traditional donut, but if a birth worker wants to speak about that, I know it comes with like an ice pack that can be inserted, I think. Sounds like maybe moving in a good direction, I'm not sure. And then you don't need anything fancy maybe. So folding up 2 towels, running them parallel under the sit bones, good for both the perineum, if there's pain at the perineum, and also again, the tailbone will fit in that same spot. Ice can be used for, yep, go ahead.
Oh, sorry, Rachel. I was just going to say, Dr. Foy has got some great info again for us in the chat, and is making a good point about the boppy, because
okay.
right? The boppy that everybody gets postpartum, no one really needs for nursing at the beginning because you come home with a belly, which is like a nature's boppy. And so if you flip that boppy around, a really useful tool there. Thank you, Dr. Foy.
That's awesome. I had a pile of breastfeeding pillows. I just didn't use any of them, I think. Ice can be used for pain. I think, speak with your physician. As physical therapist, we can't recommend medication, whether it's NSAIDs or Tylenol or pain medication. You have to speak with your provider about medication. As someone starts to heal, we can encourage gentle movement, same kinds of things we talked about before, cat-cow, pelvic rocking, some gentle stretching. Something that we're learning about as physical therapists in pain science is we don't want the brain to become really scared of pain. So doing gentle movements where we can move a certain degree and maybe we meet a little discomfort, but we don't have to push past it, and just start to get some movement early on, depending on someone's tolerance, can be helpful. Gentle self-massage to the surrounding muscles is something that a physical therapist can teach. As someone starts to feel better, so now we're more out of the acute phase, as a physical therapist, we would work on progressively strengthening the core and the pelvic floor and the hip musculature. But someone that has a tailbone injury or tailbone pain is someone we're not going to right away say you need to do a whole lot of Kegels. We're balancing the need for, like, if we use the pelvic floor, it is going to engage the tailbone. So how do we first get someone out of pain, start to introduce some strengthening, balance the strengthening with the relaxation, and then really get them where they can both engage and relax and return to their normal activities. And I will say this, so obviously I do this kind of work as a pelvic floor PT. A lot of postpartum folks feel like they fall into kind of like a hole of care where I feel like other physicians don't really know what to do, and Dr. Foy can probably speak to this too. Like, they don't really know what to do with the coccyx. They don't want to treat the coccyx. They're really not aware if there's really any options to treat the coccyx, right? So I feel like if people go back to their GYN, their OBGYN or their midwife, it is just doesn't fall within their realm of something they really feel comfortable advising about. So then I feel that a postpartum person might not know that there is someone they can go to if they have this pain. So there are people who do specialize, and just because that's not coming from your OB or midwife provider doesn't mean it doesn't exist. So Dr. Foy is a physician who specializes in tailbone pain. And I know he sees people from out of town. If there's not someone like him in your town or you can't see him, there's a group of pelvic pain rehabilitation specialists. They are physiatrists. They're doctors of physical medicine and rehab, and they're opening up a bunch of offices in the US, and they are experts in pain and the pelvis. And there's someone, again, we don't have to just think about our OBGYNs. There are other people who will look at the body and help people that are having pain.
Rachel, could you maybe speak to, for those, I know we've got some pregnant and some postpartum folks in the group, and we have a lot of perinatal professionals in the group right now. What would be the main indicator for, okay, is it that I've done the things I can do on my own? I've done some gentle movements, some gentle yoga. I'm getting some extra help around the house, but nothing seems to be changing at the 6-week mark, at the 8-week postpartum. Where is the indicator for seeking referral or a specialist or bodywork in general?
Yeah, I think that if you are having pain at the 6 to 8 week mark, it doesn't mean that you will always have pain. So it's not, to me, that's not like a red flag, but it is an encouragement to get help, because this type of pain has treatments available. So again, I'm not worried at that 6 to 8 week mark, but I would encourage someone to get care, because I don't see a reason to continue on with pain. And definitely if someone's having pain prior to that and it's really they're not able to do what we even expect someone in the first couple of weeks to do, it's unmanageable pain, and they're really struggling, that's a time to seek out too, even if it's before the 6 to 8 week mark. So like call the OBGYN back, like tell them that this seems out of, proportion to what is expected. Ask them maybe for some x-rays or ask them for a referral. You don't have to wait the 6 to 8 weeks if it feels like pain's not getting better or it's not manageable or doesn't make sense to you for some reason in terms of what you've been told about a birth. Does that help answer the question?
Yes, awesome, thank you.
And then it's never too late on the other side. So I think sometimes after you have a baby, you might put some things off, but there's usually a reason that someone's having pain and that is treatable. So at any point in the lifespan, it's good to get an assessment.
Awesome, thanks, Rachel.
Let's see. I don't think I had too much more. Just a nice pelvic floor picture, since I love the pelvic floor, and we can go to, I don't know if there's other questions or want to have a bit of a discussion.
I'll create a little space now for folks who might have been holding off on their questions, but this is your time. Ask your questions of Rachel. She has a client after this, a patient after this, so we're gonna have a hard stop. I'm wondering, so we've talked about the wedge a little bit, and positioning. You talked about really finding that support. I'm thinking in particular for folks who are nursing and sort of creating those stations around the house. Do you suggest buying multiple wedges? Do you suggest having like a little mise en place in lots of places in the house? Any place you're nursing, you should have a setup postpartum?
Yeah, I would say, so I had my babies in a 1-bedroom apartment. I'm like, multiple nursing stations. I'm like, I don't know what that is. Obviously,
for folks outside of New York.
Anything someone can do to be more comfortable, right? Because pain has like a bunch of effects that can happen after, right? The body become really kind of sensitized to the pain, meaning that the pain can stick around even longer than the actual injury or irritation. Being in pain is stressful, and we know that like nursing and stress don't go well together. So yes, if you're able to set up, you want to be comfortable when you're sitting. So if you can set up a way to be comfortable in multiple locations, I think that's helpful. If someone can help someone who is chest feeding learn how to chest feed inside lying, if that's possible for that person and the baby, that becomes helpful. But again, my goal would be like, this isn't a long-term problem, that if someone is having pain, that they're getting help relatively early. So we're not talking about side lying a baby that's 6 months old or something like that.
Yeah. We've had some more questions in the chat. So would pelvic floor PT be appropriate for chronic hemorrhoids or anal fissures? Also, do those have any relationship to tailbone pain?
So pelvic floor PT would likely be helpful for someone that's having pain with hemorrhoids and fissures. We find that someone that's having fissures, obviously, and hemorrhoids is having a lot of pain, and pain creates muscle tightness, and there could be a cycle of a painful structure, a hemorrhoid or a fissure. Now there's more muscle spasm. Now it's hard to have a bowel movement through more muscle spasm. This irritates the hemorrhoid or fissure, and then that is cyclical. So we do find that taking some pressure off of the pelvic floor can be helpful. And then to answer the tailbone question, again, we talked about these muscles inserting into the tailbone. So what comes first, the chicken or the egg, might depend on the person. But if there is some kind of tailbone pain or there was some kind of tailbone injury and that's creating tension in the area, that could be part of the bigger picture. So people that are having challenges in many ways, it helps to address multiple structures in the area that could be contributing.
I'm wondering, because we have a little time and it doesn't seem like there's a ton of questions coming in right now, although folks, this is your time to ask questions in the chat. Maybe you can show us some of the hands-on work that that folks could do for themselves to, I know you talked about sort of the pinpoint the that sort of technique. Maybe we could go through those.
Sure. So you guys would have to kind of look at my backside a little bit, but I always tell people that I'm doing a lot of telehealth. So I'm like, I'm going to show you, but don't worry, I'm going to keep my pants on. So what I find, I don't have like a good pelvis right now, but what I find is that the muscles that lay alongside the tailbone, right, that someone can take their hand along, and I'm not facing the computer, Caprice, you have to tell me if people can see.
We can. You're looking good.
All right, I can rest my fingers inside like the tailbone, and I can feel with my fingers almost like playing a piano. So I'm kind of like, I would be deep in the cheek, and I'd see like, which finger, if I push into the muscles, are giving me the discomfort. And then I would press and hold and do some breathing and see if that tension will change in the body. So I have people do that along the side of the tailbone as the muscles insert. They're feeling, is it this spot or this spot or this spot? Is there tenderness along this muscle? And we used to think that we push on a muscle really hard, we cut off the blood flow, the blood comes back and we feel great. But now there's some different ideas about why this kind of massage technique helps. And we think that maybe we're inputting a signal to the nervous system, signal goes to the brain and nervous system come back, and it changes the tension. It's like a different type of stimulus. So doing some trigger point release alongside the tailbone can feel good, especially if that is a source of pain. If you go there and everything feels great, then it's not those muscles that are contributing to the discomfort. So that's one thing. And then this has a very not medical name, but I learned this from a mentor, and she calls it the butt cheek spread. So not super scientific, right? Someone's usually lying on their side, but the same idea after the trigger point massage, someone can take their hand and just towards the side, or usually they're lying up on their side, and just do a little bit of a stretch, taking the tissues away from the tailbone and just creating some space and doing some deep breathing. We also do a little bit of a mobilization to try to encourage the tailbone from coming from a tucked position to an extended position. So I can show you that quickly. I would say, like, as a disclaimer, this stuff usually it's good to work with a PT to learn these things first, but just to give you an idea of some of the things. So we teach a technique where we rest our hand along. I'm going to use my middle finger, but not to offend you guys. It's just the longest finger there. I rest it along the tailbone. I'm not going underneath the tailbone to pull it out. I'm just resting it on the fascia and connective tissue. We have someone slouch down, do a little pelvic floor contraction. So they have them slouch down, little pelvic floor, then we have them release. And I'm just kind of pulling the fascia up, 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 just to see if they have pain in sitting, and maybe they're sitting kind of on the tailbone. It gives them a little bit of relief. So that's not these aren't evidence-based techniques. They seem to work well for some folks, whether it's because the brain has a different sensation or we're actually moving things. That I think is up for discussion in the PT world. But those things tend to help. And then things like when we're doing things like cat-cow, when we're up in that cat position, thinking about the tailbone, untucking. Usually in my clients, I find that they're pulling their tailbone under with their pelvic floor or with their positioning. So just emphasizing that the tailbone can be free to untuck in those positions.
I'm remembering that I've heard you call that little pull back that you just showed, the stuck drawer technique, which I thought was a really great name for that.
Yeah. So the idea is if the draw was stuck, that's why you do the little Kegel first. It's a little what we call contract, relax. It's like if your draw was stuck, you kind of push it in a little bit first to pull it out. And again, we think maybe it works more through muscle control than I'm actually like dragging the tissue. But people seem to, if they're having pain in sitting, sometimes it tends to take the discomfort away.
We've had some other questions about, so lower back massage helping with pelvic girdle pain. do you know why that is? Is that fascial connection? Is that just the connection of the musculature of the spine affecting the tailbone or the pelvis in general?
So I would say if there's pelvic girdle pain below the low back, then to me the low back is compensating for something going on below. So it depends. So I refer to pelvic girdle pain as like pain at the pubic bone in the front or the SI joint in the back. And to me, that's usually an issue of, it's funny, we say like instability or loosening of the pelvis, but the science researchers are telling us that we can't correlate how much the joint is loosening with someone's pain. So maybe it's not the actual loosening giving them pain. Maybe it's a motor control, muscle control issue. Again, this is kind of up for discussion. But usually if I see pain above that, I'm thinking compensation. Like I'm thinking that there's a muscle working too hard to make up for something that's not working efficiently below. So I think it's, look, if someone's having pain in their low back, it's going to add to their general pain. So I think that treating that is a good part of the treatment. And then if someone was able to troubleshoot how biomechanically to help somebody below the low back, that might get the low back to relax a little bit more.
Oh, this is a great question. Are all PTs taught about working with prenatal patients, or do I need to find someone with a certain certification?
It is such a good question. So in the US, there is not like one specific path for pelvic health therapists right now, which I really think hopefully will change in the future. So all physical therapists graduate as generalists in physical therapy, and the amount of education they get with the perinatal population depends on the school that they went to. So when I graduated 12 years ago, I either missed the day that they talked about pelvic health, but I don't think I did, or we didn't have any. So that's changing now. More schools are having a maybe an elective or a semester on pelvic health, but the people that are practicing pelvic health as of now have sought out the specialty on their own through continuing education, through mentorship, or through residency, but there's not a specific certification. So that's a little bit tricky to find. So you're looking for someone that does pelvic floor work, maybe has a little bit of experience in pelvic floor work, has taken some courses to learn the internal work. I think the birth community often knows who these folks are, so that can be a good resource if you ask in your local community who the providers are in your community.
And a good reminder too that no matter where you are, that there's lots of folks doing telehealth right now just because of our current situation. So I know you're seeing people virtually. Dr. Foy, it sounds like, is seeing people via telemedicine, and so that's a secure way to be able to get care. I think probably especially for folks in areas where there might not be a pelvic floor PT or a specialist, within driving distance. Lots of folks have really spread out, and maybe that's a better way to see folks right now.
I will say as PTs, we're a little bit limited in terms of our licensure laws. So I am licensed to only see people in New York via telehealth. I think for physicians, it might be different. I might be able to see someone within 15 miles of New York. So sometimes New Jersey, but yeah, so it's a little bit frustrating for us as PTs, just as an aside, because as a personal trainer, someone can see you from all over the country. But our licensure laws right now are limited to the state that we are licensed in.
Interesting. Dr. Foy, is that the same for you?
Oh. Is it easier to speak? Sorry.
Yeah.
Yes. Yeah. You can hear me okay?
Yeah.
Yeah. So yes, they relaxed a lot of the laws for for telemedicine across state lines, and I'm not sure how much of that applies to physical therapists. As my wife is an OT, and we know that a lot of times when certain healthcare things get put in place, people will think of the doctors and the nurses, and then they'll forget to put in a language into the statute to allow the same thing for physical therapists, occupational therapists, speech and language pathologists, So I'm not sure. You would need to check on that. But right now, yeah, we're seeing people from around the country, which it's definitely easier than flying in the middle of a pandemic.
Yeah.
When it's not a pandemic, about 35% of our people, fly in from around the country or sometimes internationally. But but obviously with the pandemic, it's just, New Jersey has 41 states on the quarantine list now. So
easier to call in.
yeah, it's easier to
Awesome.
do.
Caprice, can I speak to Lee's comment for a second in the chat? So something that Lee wrote about is that a lot of people after having children might be kind of holding tension because they either feel like if they let that tension go, they have more pressure than feels normal to them, or they're scared to have more pressure. Their pelvic floor feels like it doesn't quite have enough support. And I just want to say that I find that that's super common. And even for us as therapists, that's kind of the art of figuring out where someone is. And if someone is symptomatic in their pelvic floor, a lot of times I see clients who are pretty sure they're symptomatic because they have a decreased support in the pelvic area. So they have a pelvic organ prolapse. And then we actually go and check the pelvic floor, and the pelvic floor is actually maybe in spasm. And sometimes that's causing symptoms of pressure or pain or fullness in the rectum. So it is like, I do find that that's a common thing to try to tease out, is that there can be both some weakness in the connective tissue and some over engagement of the pelvic floor, and that's not unusual. And then trying to balance it out, like, can we get someone stronger, but also get their brain used to feeling like, where is the relaxation, and is there kind of a medium for that? So, and I'll comment too, Dr. Foy had a comment. I was trying to read the chat box a little bit about the challenge of trying to figure out, like, the chicken and the egg thing. Is it the pelvic floor causing the problem, or is the pelvic floor reacting to something different? And that's where, as a physical therapist, I rely a bit on physicians, and our strategy is, my area of expertise is the pelvic floor. I can try to treat that out. I do think if that is the issue, someone should feel better pretty quickly, and maybe not 100% better, but it should be an obvious difference. If the pelvic floor is the pain generator or playing a big role, treating it should help, and that should give us an idea. So that is, again, kind of the art of medicine in general, trying to figure out what's playing which role.
Excellent. Do we have any last questions? I know there's lots of birth workers here, some movement specialists. I know we have some pregnant folks with tailbone pain themselves. Any other questions that you have for Rachel? We have just a couple more minutes. I have really all kinds of questions, and I could sit here and talk to you all day about this.
I have a comment, if that helps.
Yes.
I will say that I think sometimes people think of physical therapy as like this big commitment, where the old style of physical therapy was like, okay, you have to go twice a week for 6 to 8 weeks. And I just want to encourage people that many of us have over the years transitioned more to, let's see what's going on and give you strategies to help yourself. And you don't have to be kind of, you don't have to commit to this like long treatment protocol that nobody has time for. So that wasn't the best way of saying it, but I just want people to know that, like, it's okay to reach out to a PT and have one assessment if you're pregnant and get some strategies and get learn how to do some things on your own. And it might be enough. It might, you might still want to get some other body work. I often see clients for the very biomechanical things, and I'm happy for them to have body work done by other people to try to maintain some of those changes. And that tends to work really nicely. And as a PT, working as a team with other body workers is super important, especially in pregnancy, because there is an unpredictable part of the body where if someone's not pregnant as a PT, I kind of know A plus B equals C. And in pregnancy with the baby and the baby's position and that effect on the sacrum, we all lose a little bit of control. So having other professionals that can, if it's acupuncture or massage or, help people feel better, is helpful.
Is there any that you find to be more complementary than others? You'd like people to, veer more towards acupuncture or towards a, Webster certified chiropractor, or is it all sort of whatever works?
Let's see. Sometimes it depends on the issue and what somebody likes, to tell you the truth. We know that the body, like if a treatment feels good to somebody, the body will respond well to it. So I think I like it all. Massage, cranial sacral. Chiropractors, I think chiropractic, it's very broad, just like physical therapists. So some are more manual with adjustments, some are more neurological. So I think what works for the client, but I do really rely heavily on body workers in pregnancy. So I like it all, I think.
Great. So if there aren't any last questions, chat box is still there, but I will just throw this up here for folks who might be interested in upcoming community conversations with us or upcoming classes. The next community conversation is tongue ties through the lifespan. So if you are a birth worker, if you are a parent of a kid with a tongue tie, or maybe someone who might have a kid with a tongue tie, great info here coming up. So, thank you for all who joined. And Rachel, you want to talk about where they can find you?
Sure. Let's see. So, sorry. I don't know if you guys hear that. That's just my client texting me. Where can you find it? Okay. So online I'm just finding to be really great. And that's for anyone in the state of New York. In person, I am on Long Island, and that is in a place called Kings Park. It's about 20 minutes east of Huntington. If anyone knows Long Island, it feels like it's in the middle of nowhere and there's deer, but it's okay. It's good. And I have a website. So my name, rachelparrotta.com, and people can message me or schedule appointments. I'm on Instagram way too much. So Rachel_Parrotta_DPT. And those are the main places.
Awesome. Rachel, thank you so much for giving us all this info today. And thanks to all of you for joining us. And we hope to see you at another Birthsmarter talk or class soon.
Thank you so much.
All right.
Hi, Ashley. Thanks, guys.
Bye, everyone.